ask your questions, and we have about 15 minutes to half an hour. So raise your hand, and we'll pass the microphone. Okay, I'll get to you in a second.
I guess my first question is, my husband has an anaplastic astrocytoma. It was a total resection in 2012. Went through standard treatment of chemo radiation. All of his consequent MRIs have been clear, but we still have had breakout seizures. He did lose vision from the resection, so he's no longer able to drive since then. Cognitive issues. And my question is, what are the chances of reoccurrence? I mean, is it guaranteed? I feel like I'm just like waiting, and it's awful. And I just feel like I'm waiting.
Okay, thank you for your question. So the question is, with an anaplastic astrocytoma resected 7 years ago, no evidence for recurrence yet, what is the chance that it's going to come back? Just to clarify, I presume this was an IDH mutant astrocytoma. Do you remember that? It's okay if you don't have it. It's okay. So I presume that your husband has what we call an IDH mutant astrocytoma. And IDH mutant gliomas are the ones that happen in younger individuals and have a favorable prognosis. So those tumors are more slow growing. Patients live for many years. I wish I could tell you that it will never come back. It's possible, but unlikely, unfortunately. And the problem with those tumors is that when we do surgery, we try to remove as much of the tumor as possible. However, it's well known from the biology of the tumor that the tumor cells infiltrate normal brain centimeters away from where the surgeon does the surgery. So that's why, even though I'm a surgeon, I know that surgery for glioma is not curative. Instead, what we try to do with surgery is what we call cytoreduction. Take out as many tumor cells as possible safely, so the radiation and the chemotherapy have a better chance of working. That's also why I and Dr. Solomon too, we have laboratories where we try to study the biology of those tumors, because we think that the answer, the cure for those tumors, is not going to come from the surgery or the radiation. It's going to come from the biology of the tumor. So I'm thrilled that he's doing well. It's very encouraging. There are sometimes in certain locations of the brain, where the surgeon can be a little more aggressive than usual, and sometimes we hear about unusual stories where patients get cured. It's very rare. It is possible, but unlikely. We have a question here.
I'm back as well, and then after you, we have a question over there. I saw a hand, so I'll make sure to get to you. Okay.
Good morning, Dr. Solomon. My name is Derek. I'm the son of my father, 86-year-old male, living in suburban Connecticut, diagnosed 26th of August, GBM, grade 4. The IDH1 is wild type. The MGMT status is not detected. He's no symptoms today other than some slurred speech. The other presenting conditions are chronic kidney disease, hypertension, and chronic obstructive pulmonary disease. The question relates to the use of contrast in MRIs, or if I got that scan wrong, a scan with contrast. And my question is, what is the contrast contributing to the diagnosis? So after treatment, chemo, radiation, you wait 30 days and you do a scan and there's contrast in there, and for anyone with chronic kidney disease, having that contrast running through your system is not a good thing. I'll leave it at that.
So I can start on that, and then if Dr. Plakatonakis wants to comment as well. The contrast actually does provide us some very important information. It's very difficult to see in the context of a glioblastoma to visualize if the tumor is growing back without the contrast. We really can't see it. And though I very much appreciate your concern about the use of contrast with kidney disease, surprisingly, unlike the CAT scan contrast, which is a very different, unrelated contrast, the contrast that's used for MRI is actually quite safe. And it has a very low risk of damaging kidneys. Now, it's not to say we would just run out and use it all the time. Sometimes they'll do half a dose of contrast. There's various forms of it. They're all gadolinium-based, which is the chemical we see, but there's some that are sort of have better data in terms of kidney sensitivity. But they are really important for us to monitor the MRI. Now, having said that, as you heard us talk about before, our primary concern is how the patient is doing. So how your dad is doing, how he's functioning. And so that's more telling than an MRI. But if we have an opportunity to, say, intervene with a alternative treatment or clinical trial, we want to make sure we do that at the earliest possible point. So even sometimes the MRI starts to show something, but the patient's feeling fine, we want to make sure we don't miss that opportunity for, oh, okay, well, we could do something now. And so that's another reason we do it.
Yeah, I agree. MRI contrast is safer than CAT scan contrast.
Sylvia, do you want to comment? Because you're often scheduling these MRIs for folks where, and sometimes they have, renal insufficiency. And so what we sort of do, what are the steps to kind of get them evaluated to see if they can get contrast?
A lot of times, I'm Sylvia Crispino, by the way. I'm one of the nurse practitioners that works with the Neuro-Oncology group along with Minerva and Dr. Kurz. And what we usually do when we first see a patient is we do a whole blood panel just to make sure that we do check the kidney function, the liver function, and also the complete blood count, just to make sure we have a good baseline and just to, before we start doing any other tests and so forth. So.
Good morning, everybody. My name's John. I got a question. My mom was a 11-year glioblastoma survivor. She was first diagnosed in March of 2004, and then it came back Christmas of 2015. She had first time with stage 4 in the right side of the brain. I remember saying right side controls the left side. When it came back, the same spot grew back, and another one grew on her spinal cord, but this time it was affecting her right side before she passed. What would have caused that?
Could you repeat, please? Where was the original site?
The original one was on the, no, it was on the right side. It was on, actually, yeah, it was on the left side, but it affected the left side of her body still.
Which part of the left brain?
That I don't, yeah, she knows a bit more than I do.
So there are certain parts of the brain, for the most part, the part of the brain up here, it's called the cerebral hemispheres. They control the contralateral part of the body, the opposite part of the body. There's a part of the brain back here, it's called the cerebellum, which controls the same side of the body. So the right cerebellum controls the right side of the body, but the right cerebral hemisphere controls the left side of the body. Pardon me?
So it was in the rear of her brain, and during the surgery, she had a stroke. So when she got up out of the surgery, she was paralyzed on the left side, and she couldn't speak either.
Oh, I'm sorry to hear that.
It's okay.
And so the tumor was on the right?
The left side.
The left side,
Yes.
the rear. Okay. So, and the side that was weak was also?
It was the left side
Yeah.
of her leg and her arm. She couldn't move, but she did regain her speech after a month of therapy.
Okay. So I presume, I'm wondering whether the tumor was in the cerebellum.
I believe it was. I'm
Yeah.
not sure.
So the cerebellum controls the left cerebellum controls the left side of the body.
Okay.
It's the exception to the rule that the body and the brain are crossed.
So his question was, when it came back the second time, why did it grow so fast? And then it also affected her spinal cord. and it hopped onto her right side of the brain.
Yeah, glioblastoma can come back fast. It depends on many things. It depends on the molecular makeup of the tumor, some of the markers that Dr. Solomon mentioned before, the IDH mutation, the MGMT. It depends on a lot of things. Tumors in the cerebellum can be a little more prone to dissemination, to cells going up and down the brain and the spinal cord. It's easier for those cells to start floating in the fluid, the brain fluid, cerebrospinal fluid. I'm sorry to hear about all that.
Yes, thanks for sharing your story. Yeah. And I will just say that you can kind of think about when tumors come back, sometimes after they've had a lot of treatment, you've selected in sort of a natural selection way for cells that are more resistant and maybe are able to outgrow other cells. So it sometimes seems like they're coming back very fast. The other thing I often explain to my patients is that by the time we see something on an MRI, we've gone from maybe a few cells to a billion or billions of cells. So it seems like it's happening very fast because now to double the size, you maybe have to go from 1 billion cells to 4 billion cells, so 4 times the number of cells. But actually, it's been going on for a long time to go from that 1 cell to the 1 billion. That took a long time. And then now to see a small change in growth only needs a little bit of doubling of the number of cells. So.
I have a question here.
So my boyfriend has glioblastoma, and he's been experiencing a lot of issues lately. When he first did the biopsy, he came out of the biopsy with aphasia and the loss of his right peripheral vision. He really been able to do well. Now, the last couple of months, he has been diagnosed with type 1 diabetes. He pretty much had a minor stroke, and I'm seeing all the information that's going on. His doctors are giving him the MRIs with and without contrast and the perfusion. So what they keep telling me is that there's no blood flow, so they're seeing it more as a radiation effect. So is that something that you would kind of agree with?
Okay, thank you for your question. So just to recap, what you told us, there's a tumor on the left side, and after the biopsy there was problems with the speech and the right peripheral vision, and then he was treated with radiation and chemotherapy, correct? And now the doctors are saying that the blood flow to that area is low, and therefore they think it's more likely to be an effect of the treatment rather than tumor. So this is not an uncommon diagnostic dilemma, whether there's actual tumor or whether it's treatment effect. And sometimes we use the blood flow as a marker of what it may be. So generally speaking, tumor is more likely to have high blood flow, whereas a treated area is more likely to have reduced blood flow. It's a little hard to tell, and sometimes when we can't decide, we just watch the patient. Or if we are convinced, or there's more compelling reasons to think that it's one or the other, we change the management accordingly. There are some patients that have one of those markers that we mentioned, MGMT. Is he methylated? So methylated MGMT patients for tumors are more likely to develop this treatment effect. It's called pseudoprogression. So that could factor into the management, perhaps. Has his speech and vision improved? Uh-huh. Okay, so things are getting a little worse. Yeah, it's a little hard to know. And how is he being treated right now? He's still on steroids. And is he still on Timodor or not? Okay. It may be worth getting another opinion. I'm not sure. Eric?
Yeah. It's, of course, hard for us to judge here, and we don't want to second guess your providers, but it might be worth just asking about alternative treatment. Sometimes, if there is radiation necrosis and there can be symptoms, typically on steroids we start to see a reversal of those symptoms. And then if it requires long-term steroids, sometimes we use a drug called bevacizumab to reduce the chronic inflammation that's occurring. And if we see a response from that, that kind of makes us feel a little more comfortable about this being necrosis and not tumor progression, because that kind of gets rid of a lot of that swelling that's causing the symptoms. It has a downside, just in that it confuses the way the imaging looks. So once you give bevacizumab, the enhancement kind of disappears, and which makes, again, looking at those MRIs tricky. Kind of getting back to your question about why we need contrast. Well, we kind of take away that advantage of visual advantage by giving the bevacizumab. But again, you can give it and then stop it, and if you get that improvement when you give it, it supports that radiation necrosis diagnosis. And I'll.
You have a question?
Oh, I don't know who's first, but I gave a mic over here, and then.
Oh, okay.
And I'll ask you to talk like a rock star, so the mic is right in front of your mouth.
Okay, will do. So my question is also about CT scans versus MRIs for glioblastoma. We unfortunately have just experienced an issue with insurance deciding that they wanted to cut off MRIs frequently for us. So we had a CT scan without contrast done a few weeks ago, and we're going to now see if. So they want to go every 3 months for MRIs, even though his doctor had recommended every 6 weeks. So we were going to do like an alternating CT scan without contrast, and then in the 3-month marker, the MRI with contrast. I'm just wondering if you could talk about how effective that is versus the contrast MRIs, if it's worth it to do that alternating, and then is it safe to get those frequently as well?
So, well, it's certainly safe to get MRIs, as far as we know, at really any interval. And the CT, especially without contrast, really only tells us if there's a very large mass effect, pushing in the brain, but it doesn't give us any of the detailed information, unfortunately. Yeah, I sympathize with what you're going through with insurance. As a physician, I'm often doing calls with insurance companies on just this issue of the MRI frequency. It's a common thing, and I can't always convince them. There's clearly a cost differential that they're very sensitive to. It's a very significant cost difference between a non-contrast CT and an MRI. It's probably 10 to 1. So that's their reticence to do that is related to that. Also, the guidelines that many cancer centers follow, we'll talk about follow-up intervals at a particular time, depending on when the treatment was. And sometimes insurance companies interpret that to mean that that is the exact time you have to do it. But every situation is really very individual, and if you're being asked to follow every 6 weeks, there's a very good reason for that, and that becomes a real battle. And I'm sure your doctor has called the insurance company. They do what's called a peer-to-peer call, where you make the case. Very often it's hard to get someone as knowledgeable as the doctor who's calling on the other end of the phone. And so I'm often talking to a family practice doctor or somebody like that who doesn't know anything about neuro-oncology. So having said that, changes, going every 3 months with the MRI still may be okay. So I wouldn't, I would still obviously get those, and you may be that, they're very sensitive, so they may be able to pick up, the growth may not be that significant if it happens in that 3-month interval, so maybe okay. Obviously, I would certainly encourage the doctor to keep fighting, at least try to get every 2 months. I usually have good success with 2-month interval.
It's an easy question, but you said that MRIs are safe, to get frequent. Are CTs safe as well to get them frequently?
Yeah. So CTs do result in a radiation exposure And for the general population who doesn't have an oncologic, a cancer diagnosis of any type, we, especially for children, we want to minimize CAT scan radiation, because if you don't have any cancer, there's a small risk of getting cancer later in life from having had CAT scans, so especially in kids. So they get very small doses to children when they have to do a CAT scan. But that risk is really very, very minimal, and the risk of not getting a good diagnostic and information is much, much higher. So we don't tend to worry about it. And actually, modern CAT scans, they kind of have dialed it down, sort of not up to 11, we're back down to about 2. And so we really have dialed down the radiation dose. And so it is safe. The contrast agent that's used for CAT scans, when you do get it with contrast, has a slightly higher risk on the kidneys than, say, the MRI contrast. But even then, it's very easy to monitor and manage. And so it's safe.
Thank you.
Okay. I'm gonna switch
Yes, good morning, and I want to thank you for having us here. I'm a relatively new part of a caregiving team, and basic question, can you explain generally what an IDH mutation is for me?
Sure, I think both of us are deep into that. So there is a gene, actually 2 genes, one that are called isocitrate dehydrogenase. One is called IDH1 and the other is IDH2. Geneticists aren't very clever with the names. These genes normally exist in all of us in a normal way, and they make a protein which is involved in how we generate energy from the food we eat, the sugar. And so they're involved in that. The mutated form, so every gene we have in our body occurs in 2 copies, and the mutated in the form that's found in some tumors results in an alteration of that protein so that it makes a chemical byproduct from this normal function, and we think that that chemical byproduct is involved in the way the tumors form. Some people think that that chemical byproduct also is involved in the way the tumor is maintained. So the tumor can form some years back maybe from some cell in the brain, and then also the tumor exists, and so there's a couple of things about this. We know that the patients with tumors that have mutations of these genes, of IDH, have different, what we call natural history, a different clinical course of the tumor and of the patient when that is present than if it's absent. Okay, so the tumors act very differently. We actually think of them as different tumors. So what's a confusing thing is that the name, like glioblastoma, is given because of the way it looks under a microscope. And the original name, which we don't use anymore, is glioblastoma multiforme, which is because it had multiple forms. There's a bunch of things that kind of were lumped together to call glioblastoma. But in the modern molecular age, as we like to say, we've come to realize that even so glioblastoma with IDH mutation and glioblastoma without IDH mutation look the same under the microscope, they're completely different tumors with a different biology, a different way they impact the patient, and a different way they respond to treatment. And so we need to know that IDH status in order to be able to kind of know what to tell you about how the tumor's going to grow, but also in order to make decisions about what kind of treatments to give. And it impacts surgery, in fact, and I'll let Dr. Plakatonakis talk about that. It impacts downstream clinical trials and chemotherapy. And it is, and there are therapies that are under investigation today in clinical trials to look at specifically targeting the mutant form of that protein to block its function. It's what's called an enzyme, so it converts one molecule from one thing to the other, and to block it, that conversion effect of that enzyme using a drug. And there's a couple of drugs out there. We don't know if those drugs are going to work, and they're very much early in development. Some of the earlier drugs didn't work. We're not clear on that fundamental question whether if you block this mutant IDH from functioning, whether that will impact the tumor that exists already, or whether blocking it would only have an effect on the original development of the tumor when it first developed, when we didn't know it was there in the first place, so we wouldn't have given a drug at all. So that's the conundrum with them, but there are these drugs being developed. It'll be interesting to see. We're very much focused on that now, what's going to happen with those.
Is there a benefit for having a IDH1? I know it's kind of hard to say, but...
Right, so it's a tricky question. We don't want anyone to have a brain tumor. If you have to have a brain tumor and it has to be a glioblastoma, there is, on average, patients that have an IDH mutated glioblastoma have a better survival than patients that have no mutation of IDH. But we think IDH mutation is actually forming the tumor in the first place. So we'd like no one to have an IDH mutation in their brain cells that leads to the tumor if we had a choice. But that's kind of where things are. So yes, on average, tumors that have mutation of IDH result in a better outcome. And the low-grade tumors, which are things like the oligodendroglioma we talked about before, the astrocytomas, the anaplastic and diffuse astrocytomas that we talked about briefly with your question, those typically have mutation of IDH, and patients do a lot better with those than those that don't. Sorry, Dominic, anything you want to add to?
No, I totally agree. They're just different tumors, the ones that have the IDH mutation versus the ones that do not. We call them gliomas, both of them, but they're totally different tumors.
Oh, she just beat you, I'm sorry.
Okay, a couple questions that I think is, more general as opposed to, my long story. I had taken the 5-day on, 23-day off of the Temodar and didn't tolerate it so well, so they switched me over to a daily low dose. So I think it's important, I don't know if you can speak to that, as to the difference, and, just let people know about that. And then my other generalized question was, where did it go? I don't know, I can't find it.
It's okay. Maybe I'll have you, just so you're ready, we'll hand the mic down to you. And then, yeah, sure. So there's been many what we call schedules of temozolomide or Temodar that have been tested. There is the standard one, as you say, which is the high dose given 5 days every 28 days, so 5 days, then 23 off. There's what's called dose dense, which is similar to giving it every day. There's standard daily dosing, which is a lower dose. Dose dense is a little bit higher dose every day, but not as high as the amount we give every 5 days. From an efficacy, in terms of looking at how well we control the tumor, they're basically equivalent. The issue becomes the toxicity to the bone marrow, which is the primary toxicity from temozolomide. So our blood-forming elements are in the marrow of the bones, and the key one that seems to be affected most by temozolomide are the platelets, which are the elements that are involved in clotting to prevent us, when we have an injury or something like that in our circulatory system or to ourselves. And so the platelets tend to be very sensitive to temozolomide, and in some people they're so sensitive that the level gets really low. And so by changing when you give it, you can kind of give the platelets a chance to recover enough that you can continue to get it. But from an efficacy perspective, they're really equivalent. We saw there were some big trials that tried to say one was better than the other, and it wasn't. So now it's your turn.
Thank you. Would you each be able to talk a little bit about what you see personally as the most innovative, exciting research and treatments coming along for glioblastoma?
Okay, that's a great question. Everybody's going to say, every researcher will think it's their own research. That's the best. But seriously, so thankfully, the research community has been sensitized to the unmet need in this disease, glioma and glioblastoma. So there's more and more folks who are spending time trying to understand the biology. So there's multiple areas, multiple treatment approaches that are being pursued, both in the laboratory and being translated to clinical trials. So you've probably, of course, there's conventional small molecules that are being pursued that target different signaling pathways, and those have been tested in trials for a long time. More recently, people have been thinking about immunotherapy, and immunotherapy comes in different forms. Immunotherapy is a hot topic in oncology right now. There's different forms of immunotherapy. The traditional form, the one that has gained the most traction so far, is those antibodies that inhibit checkpoint mechanisms within the immune system, and those antibodies actually unleash the immune system against tumors. So that has worked well for other tumors. For example, melanoma is the poster child for what we call immune checkpoint inhibition. It hasn't worked so far in glioblastoma, unfortunately, and we had some recent trial with conventional immune checkpoint inhibition that failed in glioblastoma. There's other forms of immunotherapy that are being pursued. For example, there's a technology called CAR T cells. These are immune cells that are engineered, the immune cells, the T cells we call them, they're taken from the patient and they're engineered to target the tumor. And that's been successful in blood malignancies, and it's being pursued in glioma and glioblastoma. And of course, there's many other immuno-oncology approaches to ways to trick the immune system to target the tumor. The problem is these tumors are what we call immunologically cold. So the immune system is not activated a whole lot by glioblastoma. Another approach that is being explored has to do with gene therapy and viruses. Putting viruses in the tumor that will do different things. Some viruses will kill the tumor. There's other viruses that will invite the immune system to come in and clear the tumor. The past few years, there was a large-scale randomized trial using a particular virus that was meant to kill the tumor when a certain drug was given, a pill. And unfortunately, this clinical trial failed. It was announced this past week or 2 weeks ago. But there are many other gene therapy trials that are being pursued. So to answer your question, it's hard to know what's going to pan out. But I think what I can promise you is that we as a research community are doing our best to try to attack this problem from multiple angles using multiple approaches.
Yeah, that was an excellent summary. I want to say that sometimes there's a tendency among all of us to think that what is the newest thing is the best thing. And so we see that, in our iPhones and whatever it is that we want to have, the best has got to be the newest thing. But indeed, slow and steady wins the race in oncology, and some of the greatest discoveries, including the checkpoint inhibitors, were something that had been studied for 20 years, but only hit the press, the first time in 2011. So, and of course, the guy who found the first checkpoint inhibitor just won the Nobel Prize for doing it, so that means it was work that he did, when he was a young man. It's very important as a community that we stay focused on all of the many options. I'm going to do a little plug for the ABTA because they actually do a great job with that discovery grant that you heard about before, of kind of saying to researchers, hey, try something new, but also different, and see what happens. And that's kind of what the discovery grant allows us to do. But we really want to keep all our options open. So a lot of the stuff that you don't hear a lot about as much today, the sort of targeted therapies that Dr. Plakatanakis mentioned, are actually still very viable research options that are going on right now that don't have anything to do with immune therapy, but are really important that we continue to study them. And then in the immune arena, you know, there's a lot of things that get a lot of press, viral therapies, particular viral therapies that have gotten a lot of press. And it's not always, the amount of press is not always proportional to the efficacy of the treatment. And so we really want to try a lot of different things. So I think what's most exciting, to really answer your question, there isn't one area of research that's most exciting, but what is really most exciting is that today, more than any time in the past, there's a huge number of people and pharmaceutical companies and equipment companies that are now focused on the problem. We just didn't have that before. So one of the biggest gatherings of researchers and providers in neuro-oncology is called the Society for Neuro-Oncology annual meeting. It occurs every November, the week before Thanksgiving. We all get together. When I first started attending, maybe I was, you know, not that old, so I would say maybe 400 or 500 people attend. This year, we would anticipate 2,400 people attending this meeting. So it has grown enormously. The number of trials for disease, say glioblastoma, the number of trials in glioblastoma used to be you would search for trials and maybe you would find 4 or 5. Now you find probably 100 or so in clinicaltrials.gov. So things have really expanded. We think of the tumor treating fields, right? This is something that just no one heard of, and then boom, there it is. But it actually was the result of decades of research to develop it, and now we're starting to see combinations with that, just like we've been doing combinations with temozolomide and combinations with radiation. So, you know, there's not one thing that I'm going to put my finger on and say is the thing, but I am very, very excited about the number of people and the number of options that are being worked on right now. Oh, sorry. BJ. Who's got the mic? Oh, okay, good.
Yes, my name is Luis. I was diagnosed with a glioblastoma multiforme this May. I had a surgery done May 16, and turned out to be the glioblastoma multiforme. But because the surgery was done very well, they told me that it was a resection done 99% of the tumor. I had a very good recovery, but because of insurance problems, my treatment of the radiation and chemo was delayed. So by the time that I started the radiation and chemo, they already told me that I had a regrowth of 1 inch in diameter. I wonder if that was a fact, the delay for the regrowth.
Thank you for sharing your story. Can I ask how much of a delay was there?
It was 2 months after the surgery.
Okay. So typically we start the radiation and chemotherapy about 3-4 weeks after the surgery, and Dr. Solomon can speak more about that. 2 months, sometimes it's okay, but it may be a little too long. I think it's important that you are getting the therapy, and hopefully there was response to the radiation. Was there a response? Did whatever show up on MRI, did it get smaller?
We don't know yet. I had done the MRI after a month finishing the chemo and radiation, but they were telling me that it's too much swelling now, and the images are inconclusive.
Okay. And are you taking steroids?
Yes.
Okay. Okay. Time will tell, and sometimes there's during the radiation and chemotherapy, things may get There may be some additional swelling that may complicate things. But ultimately, the MRIs that you're going to be getting are going to show how the tumor is responding to the treatment. Another thing I want to bring up in relation to what you said and to what other patients and families have said here is the insurance plans. And we, as the collective here, patients, families, providers, caregivers, we need to voice our concerns. And I'm willing to fight with you. We deal with it all the time to get authorizations for diagnostic studies or treatments, and we all need to stand up. I'm willing to fight them with you.
Yeah, I would agree with that completely. And the only thing I'll say about the your particular situation is some people, even when we start at 30 days, their tumor grows, even through radiation. So we can't always know. So maybe that was an issue, but we can't know. And as Dr. Plaka-Tanaka says, time will tell. But I hope you get a good response. You're doing everything right. You're doing the treatment you need to be doing. And that's the right thing to do. And I would also echo the importance of advocacy. And we are all, as physicians and providers, we're fighting hard. And the ABTA is fighting hard. There are other organizations that are lobbying as well. And so I think anything you can do to get insurance companies to do the right thing is important. Do you mind? I think we're running over. We can talk to you one-on-one. And then, the rest of you, I think it's time for lunch. And we feel badly keeping you from that.